delay before I could, start speech therapy, what we call the oral method at that time. It wasn't until later on in my childhood years that I met other deaf friends. Is when I actually got immersed with the deaf culture community, started to have deaf friends, some more social circles there, and learning American Sign Language. So we do have a deaf health clinic that's part of the Dexter Health Center. So if anybody's interested later on, just feel free to reach out to me. I do spend a fair amount of time in now growing a little bit with medical education, especially with disability health. There's a lot of exciting initiatives that are taking place. We have a clinical fellowship program that's going to be starting in July for family medicine graduate in the residency program that's going to start in disability health. So this is, again, all of the bigger push to improve quality of care for people with disabilities, not just deaf and hard of hearing. And then the other important thing to recognize is that there's many research opportunities, both in family medicine. We have an disability program, and we also have the Center for Disability Health and Wellness. And there's abundance of opportunities, whether if you're interested in primary care or specialty care. And so if you're interested in disability health and in any type, feel free to reach out to me. So the goal for today, I'm excited that we're going to be learning deaf perspectives, clinical care, some of the struggles that we often encounter, and some strategies hopefully we can do a better job in. And so I'm gonna just turn it over to Julia.
Hi, I'm Julia Shields. You know, Captain America with a shield. That's my last name. So welcome. Thanks for joining us in the panel. I'm an ASL teacher that's going to be teaching tonight at 6:30 to 8. I'm actually from a very small town near Plainwell. We just drove 2 hours to get here. It's the Kalamazoo area to participate in this panel. I was born deaf, profoundly deaf. I don't know the word, he may know. It's M something D, meaning that my cochlea was not fully developed. Modality something, I don't know. It's a medical word. But it's the cochlea is not fully developed, and that's why I'm deaf. So all of my brothers and sisters, I have 6 brothers, 1 sister. They're all hearing. They don't know sign. I grew up in the oral method. I learned how to hear and speak for myself until I was age 20, and I went to Rochester, New York, and was exposed to deaf culture and American Sign Language for the first time and floundered. And after 20 years of going to New York, Massachusetts, Washington, D.C., in 2017, I returned home back to my roots, and I'm teaching ASL part-time. For now, anyway. Ryan. Hi, I'm Ryan. I'm her husband as well. So I was born profoundly deaf. My parents are deaf as well. I'm a second generation. I do have a brother who is hearing. He's a coda. My aunt and uncle are deaf as well. So 4 of my family relatives graduated from the Michigan School for the Deaf. That's my life. So what did you do after graduating from the deaf school? Oh, actually, after I graduated, I played around, doing odd jobs until I felt it was time to go ahead to go to the Rochester Institute of Technology in Rochester, New York. 10 years after I graduated high school, I majored in engineering, computer integrated technology. I did that for about 3 years, got my associate's degree, returned to Michigan, and I am working at a place near Kalamazoo. At the end of this month, it'll be my 3rd year. Great.
Okay, so what we're gonna be doing, we have just a few questions to kind of start this discussion. And so it'll be open up to kind of learn more of the patient perspective, and I'm happy to add more personal and also clinical perspectives as well. So,
So we're going to follow the list of questions here. So what were some healthcare barriers and struggles that you have experienced with the doctors or hospitals? Okay, I'll start. I was a college student at RIT for 3 years, and I graduated with an associate's degree. And I started working full-time at RIT for about 6 years, 7 years. The ironic part is there's a clinic there that actually had 2 deaf doctors. One of them was him. So he used to be my doctor. Isn't that ironic? So anyway, we had some hearing doctors as well. It was such a nice clinic, but communication was easy to access. But if I had to go to the emergency room, I think the hospital was called Strong Memorial. They had on-call interpreters there. And sometimes you ran into them in the emergency room. I felt very spoiled. Communication was not an issue, no frustration. Now, when we moved back here to Michigan, we faced a lot of struggles. My doctor is in Kalamazoo, and I had to self-advocate. Don't forget to schedule an interpreter. Don't forget to schedule an interpreter. And I always got the response of, oh, yes, right. I had to work very hard to make sure I had interpreters. It was a struggle and very frustrating. I would not say everything worked out as neat as it was in Rochester, New York. I was very spoiled there. Kalamazoo is aware of deaf culture, sort of, a little bit. But my being a patient there, I always ask for an interpreter. Sometimes they call me and tell me, we don't have an interpreter. Do you mind rescheduling? And that's just frustrating to have to constantly reschedule. But it's one of those things, I know it's difficult and I have to put up with. So again, what was the question? Ryan is asking, what are your barriers and struggles when you go to the doctor, communicating with staff, hospitals, whatever? So one time I had this experience. I had a really bad cut right here on my hand. It took 9 stitches. It occurred at work. So I had to go to ER. They did not have interpreters. My coworker helped me because they drove me there because of all the bleeding that was going on. So my coworker drove me there. I don't know, I guess we went a mile. And of course, I worked second shift late at night. The cut occurred about midnight. And of course, they didn't have interpreters there. They didn't even offer video remote interpreting. The hospital was very small. So my coworker had to fill me in what was being said, you know. It worked out. I mean, I understand because I grew up in a mainstream school educational program. From there, it went well. You know, they made sure I was okay. I filled out the forms. I had, you know, again, to report to work. But at that time of day, it was frustrating because there was not video remote interpreting or interpreters on site. I mean, if it was during the day, we might be able to find an interpreter, but that time of night, it was a situation that I was frustrated with. Julia's asking, did you write back and forth with paper and pen? No, my coworker did all the talking for me. We used a lot of body and hand gestures to communicate. That way I could understand. The coworker I was with, we understood each other. I didn't understand the doctor, so I had to rely on my coworker as a solution to the communication issue.
So just kind of add, there's a few points I want to just kind of emphasize. So you heard about the importance of interpreter access. So the Americans with Disabilities Act has made it very clear, and along with the Department of Justice, for a deaf signer, the accommodation is clearly has to be an interpreter. There are different ways to do that, but the interpreter needs to be provided. The Americans with Disabilities Act for people with disabilities will say accommodation can be provided. There's Title II and Title III, so you can say what can be, what's feasible, what is going to be acceptable, but understand an acceptable option beyond interpreter, there isn't really one. So for deaf and hard of hearing, it's really important to make sure, be proactive about getting an interpreter set. So in this situation, there are going to be emergencies or urgent care visits show up and not going to be able to get an interpreter arranged. So there's another option called video remote interpreting. I will just give you a little bit of a caveat, not the most popular option, but it is certainly a suitable option for an emergency or urgent request until you can establish having an in-person interpreter. So the way that works is very similar to what we have with the Zoom. An interpreter can join on a Zoom and you can have a platform. The problem with that, there are going to be limitations with it. Is only going to be as good as the sound quality. We're trying to listen in a lot of background noises. They're not going to understand, but guess what? Your patient is not going to understand. The other thing is if you're thinking about trauma, so trauma, they're going to be already in a board. They're not going to be able to bend over, look at the iPad. So again, positioning, it's going to be an issue. The other thing is if they have Usher syndrome or they are deaf blind, they're not going to be able to visualize it. So there are some clear guidelines where, you have to follow and make sure it's appropriate. So part of the reason Julia is actually our instructor for the ASL course, to be able to have some basic ASL, I think can go a long way until getting those services set up. So it's just a few things about that. In addition to the Americans with Disabilities Act, the Affordable Care Act, Section 1557 prohibits discrimination based on disability along with other disadvantaged populations. So there's just a few things right there. We'll go a bit more on other topics.
Yes, VRI, honestly, I'll be honest with you, I detest it. It's not reliable in compared to being in person. You don't have good connections. Again, you've got firewalls that are protecting the technology and makes it unreliable. I just hate VRI. The whole firewall protection, bad signals. Every time I go to the doctor and they're asking, do I want VRI? And I'm like, absolutely not. It has to be in person. They may think that it's cheaper cost-wise to have VRI and it saves money. It all has to do with money. But I always say, no, I want in person. And they actually have to respect my wishes. Yeah, I hate VRI. You've experienced VRI. Yes, I want to add to that. The noise in the background. There was an instance where they brought me the screen for VRI. We had issues with connections, but sometimes the doctor would talk and the person couldn't hear the doctor. So they kept saying, I can't hear you. So they had to adjust it so that the microphone could pick up the doctor's voice and the interpreter could see the doctor's mouth movement. And then it was that moving the screen back and forth. It really took a great deal of time. That's one of the issues with VRI.
So feel free to ask questions as we go through. The other thing you heard is also the writing back and forth. I will tell you, my handwriting is not great. Medical jargon, all of that is going to make it difficult for somebody to understand what you write out. The other thing is I had a colleague back when I was in Rochester, New York, who actually did a basically a simulation where speaking verbatim and basically writing it out word for word. And anybody want to take a stab at how much longer it took? How many times longer was it versus speaking it out versus writing it out? 10. 10 times. Okay. Yeah. So that's actually a little more, but that's a good guess. So 6 times longer. So if you're doing a 15-minute appointment, is a doctor going to now spend 90 minutes writing it word for word? No. So again, that's where communication breaks down often. And so the important thing is to recognize the patient's needs to effectively communicate and what are the tools or services that you're going to be able to accomplish that. So that's really going to be key. Interpreter access right now is challenging. Part of it is also complicated by this refusal. Well, that's not my job. Why do I have to pay the interpreter? Because I'm your doctor. And a lot of people don't understand the medical legal requirements. And so one of the hopes that I do believe that all of us, when we graduate medical school, should have at least some basic knowledge of that. And so it's important just to protect yourself. Also, you're going to be happier when you have the interpreter to work with the patient. The patient's going to be happier. You're also going to save costs downstream when you have better communication. There was one situation in when I was a resident, I was called to come over to help facilitate communication with the deaf patient. And I know a lot of the interpreters were away for a RAD registry interpreter for the deaf conference. And so many of the interpreters were gone. But this poor lady had a very simple request, could not communicate with the ER doctor. And it was just a minor pelvic issue and ended up having a CAT scan, ultrasound, and multiple blood tests. I can guarantee you the cost certainly outweighs how much it would have been to get an interpreter. This was a little bit more complicated because of the conference, but again, this refusal to get interpreters does have downstream costs impacts too. So again, do the right thing, follow what's required by the law, and also to have good communication. You're going to improve patient satisfaction and your satisfaction too. So yep.
What do interpreter services look like for people who are blind?
Interpreters for blind people, you mean, deaf blind? They use tactile. Yeah, it's tactile interpreting with deaf blind.
So with the tactile interpreting, that requires in person. So that's a case where VRI is not going to be acceptable. And so that would be one you're going to have to really make sure you get somebody in person. And that was complicated with COVID in the early years. A lot of deafblind patients were literally cut off. I mean, they were cut off from any services, any communication, because they could not have an interpreter in person. So it was devastating to them. Anything?
So anything do you want to add about access to communication before we go to the second question? So now we're going to talk about success stories, what worked, why it worked. Maybe an example was an interpreter was there, doctors' opinions, perspectives. So I don't go to the ER very much myself, but for normal doctor visits, that really helps a lot because I can fill out the information. The doctor can make recommendations. It helps with the interpreter to get all that information so I can make note of the things that I need. It's always positive when I have an interpreter with me. With VRI, it just sucks. So I have a cochlear implant. When I was about 12, my parents did all of the work. I would just sit and things would go by. And then for some reason, my CI was not working and it had to be replaced through surgery to remove it and put in the new device. And I told my parents that I wanted an interpreter for the second surgery, for the replacement surgery. So my parents said yes. I was very lucky. I had an interpreter. Communication worked out well. It was easy to understand the process. But you were very proactive on the second surgery, not the first surgery, right? Yeah. With the first surgery, I had no idea what was going on. Mostly I depended on lip reading and talking. And then when we came to the replacement surgery, I told my parents, I've got to have an interpreter. I took over the process and was very independent.
Although it's not the ideal circumstance, do patients ever bring their own interpreter to interact with like these? I know it's not what we want, but.
So I've never experienced that. Do you have to work through a nonprofit organization or work through the hospital? And they have to reach out to people. Oftentimes you just meet the interpreter when you get to the site. Did you want to add something, Ryan? Yes. So it hasn't happened to me at all, but I do have friends who have shared stories. They go to the emergency room. They always depend on their good friend's girlfriend because she's a good interpreter. She's a good signer. She's not certified because the hospital is not providing service. And again, this is a last minute kind of thing. And that always bothers me that that's the only tool they have, that we have to work through friends of friends. So, I mean, my friend's girlfriend is who we're depending on. It's a very sticky situation. It's not a good idea to take advantage of family, friends, or relatives to interpret in medical settings.
So that adds a really good point about, so this concept is called a proxy interpreter. And so we see that often, whether it's other language minorities and sometimes even with deaf individuals. So proxy interpreter, there are going to be a number of issues that will come up. Sometimes the proxy interpreter wants to just be a family or friend to support. The other thing is a patient may not be comfortable disclosing certain things. You imagine if mom was there and you had to talk about sexual activity and something embarrassing. And so there are many situations where it's clear that proxy interpreter actually damages the provider-patient relationship and communication. So obviously try to avoid. I've had some patients that actually would try to push for the proxy interpreter. That has not been with deaf individuals, but more with language minority groups. Sometimes they, because of their culture, they may want to have somebody rather than asking. I would still try to emphasize that it's important to have the interpreter so that I could do a good job and that you could just simply be there to support the family member. And sometimes explaining that can help them. So be more accepting of that. So a great question now. All right.
So do you want to teach them about how to take care of a deaf, hard of hearing patient, information they might need to know? So if they become your doctor, what would you like for them to know? So if you know signs, that's great. That's a good start, especially with deaf patients. But you always must have an interpreter, no matter what. And that's because it's hard to explain. So if I go to the doctor and the doctor is signing and gesturing, it's okay, but for a deeper, fuller understanding, you need the interpreter. It's fine that the doctor is signing and gesturing, but you really need to have an interpreter there. And I'd like to add, a good tool for you guys to learn is basic signs so that you can communicate with your deaf patient. So if the hospital or the doctor's office gets a deaf patient, it could take 45 minutes to an hour to get an interpreter in there. And then if you're able to do some basic signs like your pain, is it 1 up to 10? If you learn the basic things, and then you can verify the information that you got from the deaf patient, and it just makes your job easier and a lot more efficient.
Okay.
have physicians or other healthcare providers made other assumptions based on being deaf or hard of hearing?
Every time I need to communicate, I always tell them I'm deaf and I can't hear. That's typically the first thing we do is, we tell them that we can't hear, and we start communication with writing back and forth or texting on our cell phones. We try to do that. There's two things that really irritate deaf people. When a person says, "Can you read my lips?" It's please. You can't expect deaf people to read lips. It's impossible. So when we're asked that question, it's irritating. And deaf people do not like to be labeled hearing impaired. That's a medical terminology. We prefer to be labeled as deaf or hard of hearing, not hearing impaired. For example, little people are often referred to as dwarfs, but they prefer to be called little persons. That's a more respectful term. We hate the word hearing impaired. We prefer to be referred to as deaf and hard of hearing. I think those are the two things. That's a good question.
So just to add, I've even had experiences, especially from coming from faculty members and doctors, knowing that I was deaf. And there was one clear situation. I was purposely kicked out, failed from a clerkship rotation because of my hearing loss. And when I inquired about it, he literally told me that you don't belong here, and you took a spot from another hearing person that would be a doctor. And so even biases, stereotypes still comes up. When people see my cochlear implant, they assume there's going to be some communication difficulties. And sometimes I see people back away, never get an opportunity to learn me and be able to interact with me. So important for you guys to think about what are your biases. It's okay, we all have them. But just to be upfront, honest with them, when you meet your first deaf patient, understand that we're hearing 3 different perspectives. Everybody is going to be different. So get to know the person, ask about their needs, what their communication preferences. I still ask every deaf and hard of hearing patient that comes to my clinic. It'd be easy for me to make an assumption. I've actually been surprised. I actually have one individual that was from a different country and asked what would be the best way to communicate. And he was a computer guy, and he said, "I want to type and use our computer and go back and forth." That was the first time I've ever had to do that. I've been encouraging people to get away from that, to have interpreters or direct communication. But the reality, it's really driven by patients. We have to learn how to communicate effectively with them. And so be curious, just be honest with your biases as well. Okay.
Do you have anything to add? No. Oh, I'll just a little something to add. I do have a cochlear implant, and when I was 11, I didn't know ASL at that time. Again, my parents did all the communication with the doctors and the audiologist, and somehow my internal part at the age of 21, 22 was not working. So I told them that I wanted an interpreter for the surgery and the appointments. And I had my replacement surgery here at the University of Michigan. It was nice. So my parents, I kept emphasizing them, I want to use my ASL. I was able to communicate well. So my parents finally realized that American Sign Language is the best way to communicate, and that was really good. I would like to add as well, as a caution, while you're learning the basic signs, that's great. And we go up to a deaf patient. So here's 2 good tips. Patience, you always need to be patient. And make sure that you communicate clearly, and it has to make sure that they're understanding. Be patient, communicate, and make sure that it's happening clearly and understood. So now we have another question. If they want to partner or help advocate for deaf, hard of hearing people, are there organizations and groups that you would recommend as resources? Well, I'm not really that familiar. I know over in Grand Rapids, they have a deaf and hard of hearing services. That's a great resource. But as far as Ann Arbor, I'm not really familiar with the Ann Arbor area. So I don't know, do you know some good resources? Let's ask him. Yeah, just like she said, I was born and raised on the east side of Michigan. So Saginaw is where I'm from. It's 30 minutes north of Flint. And Flint is where the Michigan School for the Deaf is. So there's a lot of deaf organizations offering interpreting services on the east side of the state. On the west side, there's a fewer organizations, but in Detroit, in Flint, in Ann Arbor, we're close to that area too. There's a lot of resources.
So one organization here locally in the southeastern Michigan area is called the Michigan Disability Rights Coalition. And they are big in the arena of advocating for people in southeastern Michigan with disabilities and patients with disabilities as well. In addition, if you want to get involved with advocacy work, there is a national organization called the Medical Students with Disabilities and Chronic Illnesses, which our local organization here is a chapter of, and you can get involved in advocacy through there to advocate at the policy level and to connect with students with disabilities across the country.
A couple other groups is the DeafCAN, which stands for Deaf Community Advocacy Network. They're also in Southeast Michigan. The other one, if it's more legal, where there's more advocacy, policy-based work at a state level, then the Division of Deafblind, Hard of Hearing is another group to touch base, and they often will take inquiries, and if they are available, can look into that as well. I know this largely came about, this panel discussion, because of the co-grant plan discussion that you had. And just understand that co-grant plan is another resource service program that we should offer to anybody. So when I see deaf patients, I just simply give them, not encouraging or be against it. And understand that there are some individuals in the deaf community that are not comfortable with it or opposed, and that's fine. And that's part of the reason why we have to get to know the individual instead of imposing what you think should be done. So that's, again, we're thinking of more of an autistic kind of perspective. So thinking of fixing like it's a deficit versus knowing about the individual. A deaf individual may be completely comfortable with their hearing loss. I know I personally struggled for many years on whether to do a co-grant plan. I was afraid that it would change me, how I perceive me. It is a real thing. And so understand that co-grant plan is available. We should not deprive somebody who has a deaf, coming from a deaf culture. Some individuals still want to go ahead and have it, and that's fine. Same thing if we have, a deaf child, give them opportunity to learn sign language so that they have different ways to communicate. And, again, it's almost like if you go to Europe and other places, we don't stop in one language. We actually encourage multiple languages as well. So that's sort of how I kind of handle that situation. Are there any questions about co-grant plan or?
Yeah, I'd like to add, when I got to Rochester, New York, going from a hearing world to a deaf world, it was so much of a change. A lot of deaf people wanted to know why I had a cochlear implant. There was a lot of negativity associated with that. And I kept wondering, why are they so negative about it? And it's because they were worried about their culture and the loss of their language, American Sign Language. And we would all become hearing individuals or whatever. So I got a better understanding about deaf culture through that experience. Again, there's a lot of negativity, but I always tell them that it was my decision, not my parents' decision. I decided to have the cochlear implant. So you have to do a lot of teaching and you have to understand the different perspectives. Deaf people are a lot more accepting and open to this. It used to be very different, but I think they're very accepting nowadays. Or do you
The
agree?
other thing about the
Yes.
cochlear implant is that keep in mind that those who have age-related decline are eligible. A lot of people forget about it, especially primary care. We never make that referral. So I have actually made a referral for patients in their 90s to get cochlear implants. So there's a whole age spectrum, related decline. They are so eligible once they get beyond that moderate hearing loss. So just keep in mind that cochlear implants is also available for those growing up hearing and then later on lost their hearing. So it's another useful tool. The other thing important is that hard of hearing individuals is another group we really didn't touch much today. But that is another large population, often sort of invisible, because deaf people, you see them more with signing. Hard of hearing, sometimes you don't know that you have a hard of hearing patient until you ask them or screen them. And I'm a big believer that we need to screen everybody, ask them about if they have a disability or any needs. And you should also inquire about the presence of a hearing loss, especially 55 and older. So there is a best practice alert in my chart for that. So one of the things that I would love for you guys is that you guys can be our next wave of champions. Under the My Chart, if you look under patient name on the storyboard, there's a disability accommodation. I can show later, or maybe we can do a screenshot, send it to you guys. But disability accommodation, we are the first one doing it across the country. And we're hoping that this becomes a standard way to collect the data so that we can proactively meet the needs of these individuals. So be mindful as you interview, work with patients going forward, pay attention to that. We're still also educating staff members, faculty members, so that hopefully we can have a better sense of who the individuals that we're seeing. Okay. All right. I know we only have a few more minutes before you guys have to take off. Any other additional questions?
I know you had mentioned that asking people to rely on reading lips is not right. That being said, with everybody wearing masks in the hospital, I'm curious how that has affected communication and any tips for people who do rely a little bit on lip reading, how we as future providers can help rather than hurt the situation.
Thank God for the person who invented the clear mask. It's nice. It's not a bad solution, but regular masks, well, see, you can see this one, it's got the clear part. You can read someone's lips. But oftentimes if we go to a restaurant, I know this is a little bit off topic, but the restaurant people see us signing, some waiters will take their mask off and ask, can I read my lips, and ask if this is okay. And when they're done, they put their mask back on. We typically go to the same restaurants, so they know that we're deaf. We don't have to ask them to do it, but they do take their mask off because they know that I can read lips. Yeah, but COVID presented such a challenge with the mask and not being able to see lips, but the clear mask work well. But sometimes there are some words that are easily misunderstood on the lips. my struggles are telling the difference between 50 and 15. I would often say, are you talking about 5-0 or 1-5? Because it looks the same on the lips, and it's such a struggle to see that. There's often misunderstood things. I'm pretty good at lip reading, and clear masks are very helpful. There's another mask that's totally clear. This one is very narrow. Do you have anything to ask? Yeah, no.
So this is called the Safe and Clear. This is one of the FDA approved. We have it available here across the Michigan Medicine. So for it, we're trying to make sure all departments and clinics have them available. I actually had to take my son because of a laceration during dinner preparations. And so we went to the pediatric ER and they did have it. They ran out, unfortunately, when the next staff turned over. So we had to try to find more. But the point is, yes, it is a real thing. And you heard restaurant going to the food store, we are cut off. And so having this for healthcare services is really essential. There are 4 I want to mention. So Safe and Clear, as well as the Clear Map, are approved, are available here in Michigan Medicine. There are 2 that I expect will be approved, and they're a nice fit. It's called the Bed Shape and Face View are 2 other ones. So I'm hoping that there will be another supplier. One other thing I will tell you, universally, we should be using this. Kids like it. If you have other types of disabilities for communication, they like it. There was a study done at general surgery, I believe at Duke or UNC down in North Carolina, and they did a clinical trial with this. And guess who was actually viewed as more favorably, better patient satisfaction, better patient communication? Was it the surgeons that wore this, or was it the surgeons that wore a typical mask? It was actually the Clear mask. These were not people with a hearing loss. And keep in mind that people with a hearing loss in the general population right now, we have ranges anywhere from about 14 to almost 19% of the population have some self-reported hearing loss. It may not be severe enough that they can't hear through it, but the point is that there's more people with hearing loss than you think. And so try to be, this is another way to advocate to be a champion too. Okay, that's a great question. Any other questions?
Don't be shy. Go ahead. We're ready. We'd love to have more questions. Let's go.
Do you feel like some of the emotion or feeling is lost when communicating with the interpreter?
Are you talking about life in general or in the doctor's office?
In the doctor's office.
So my physician in Kalamazoo provides interpreters. So communication is very easy and effective. Of course, emotions get involved occasionally. But if the doctor is just talking, there's no emotions connected to that. I just nod my head, even though I'm not understanding anything. It's nice to have the interpreter so that I can see all of that. I like having an interpreter in my doctor's office. I've been encouraging him to use my doctor because they do provide interpreters. And so he actually transferred his care to the same place so that he can guarantee to have an interpreter.
Here we have an amazing interpreter services department. So we're fortunate, but many of you guys will end up going to private practice, a clinic, or another hospital. So it's really important to know your local agencies so you can get interpreters and understand that they have to be a certified interpreter. I've had situations where we ended up somebody that just kind of started as our instruction and was put as an interpreter, which obviously that's not going to be ideal. And also does not work in regards to the Americans with Disabilities Act for access. So, but it's important for you just to be aware, you can have your clinic manager, office manager. Be able to have a running list and know who are those people to contact, so that you're ready, so.
So a lot of us have to get going to class at 1 o'clock. But thank you.
Thank you.
Thank you.
Thank you.
Also. if you guys
I'll
can
see
grab-
some of you tonight at 6:30.
Also food in the back, you can take some food in already. Put him on the front, yeah. Thank you so much. Yeah. for all the-
And about the maps, let's talk about to vote. It sounds like sometimes it's certain